Welcome and thank you for joining us. This is the Physical Therapy Best Practices breakout session where we will be focusing on non-sitters. I'd like to introduce Richard G. and Leslie Nelson, who will take us through this.
Myself and Leslie Nielsen will be talking through this meeting. Before we get started, what I want you to do is open up the WOVA app and either by your phone or by your computer, and note the question and answer tab on the right-hand side of the computer app. There you can ask your questions and we'll get to your questions as the meeting goes. There'll be time near the end to ask any questions and we'll answer them as well. Myself, my disclosures, I'm on an advisory board for Biogen and Roche, and I'm also a consultant with Biogen. And Leslie Nielsen is also a consultant with Avexis, Roche, and Aduntis, and she is on an advisory board for Biogen and Scholar Rock, and she's also on the speaker bureau for Genentech. So the outline for today is that we're going to review the standard of care recommendations, and this was published in 2018. This is the second update, the first updated set of standard of care recommendations. And then we're going to go through 3 case presentations. There'll be an infant case, a child adolescent case, and an adult case. We're going to go through their impairments, their activity limitations, and their activity participation. We'll go through what assessments we use and evaluations we used with them. We'll go through treatment planning and goal setting, go through interventions and medical equipment recommendations. At the end, we'll go through general considerations for the non-sitter and also community resources for yourself that you can use to augment your practice. I'm not sure if this is on the polls, but the poll questions are you currently managing children with SMA non-sitters? Not at this time, for the last 5 years, 5 to 18 years, greater than 18 years. Natalie, is the poll open?
Yes, it should be. 1 second. I'll work on that if you want to.
Okay. And the second question is, are you treating the children with SMA at home or at school, or an outpatient center like a hospital, outpatient center, or an inpatient center? And the third question is, what are your experience with the treatment of patients with SMA that are non-sitters? Have you seen them never, less than a year, 1 to 5 years, to 10 years, 20 years, or more? Here are the primary goals for non-sitters. The primary goals for non-sitters are to optimize function. And that is also to include both compensatory and habituative function. Also is to optimize tolerance to various positions, both supine, sideline, and upright positions, looking at developing strength, developing skill development into various positions, and also to look at, can we provide opportunity that they can do movement? Can they learn movement they haven't had from before? And the third primary goal is to minimize impairment. Now, this is from the standard of care document in 2018, and that document talks about the diagnosis and management of SMA. And in this document, what we did is we asked a couple of questions, and we asked a panel of experts, and we give them a question. The first question was this: What was the signs and symptoms of the most important problems pertaining to physical therapy and rehab with the children with SMA? And we're specifically talking about non-sitters. We talked about both non-sitters, sitters, and walkers, but today we're going to talk about non-sitters. And in that questionnaire, we did a Delphi review of that, and we ranked order from the most important up here to the least important. And out of the group, the most important was the signs and symptoms of muscle weakness. And that showed decrease of anti-gravity movements. And that was noted more so in the functional scales like the CHOP and 10. Going down in order is postural control, including the head and the neck, in both postural control in supine, sideline, prone, as well as upright positions, contractures of the limbs, arms and legs, and also including the neck and the jaw. Also including scoliosis, chest deformities, head and neck deformities, including plagiocephaly. Also down the line, including pain and fatigue. More importantly, when you look at this group, we all think at the type of kids that we see in the clinic as non-sitters. The first thing that jumps out to us is immobility. But if you look at this order of agreement, immobility or mobility is a little bit lower for the signs and symptoms. We really are more focused in on the muscle weakness or the lack of anti-gravity movements or the lack of range of motion through the limb and trunk, or the deformities of the body. And that's somewhere to think about when we are identifying our plan and identifying our goals is, are there areas that we can focus in on that are more important in the signs and symptoms? Lower down in the signs and symptoms are hip dislocation, skin breakdown, pelvic obliquity, and fractures. Now, in that same questionnaire, when we asked that group of panel of experts, we asked the second question. And the second question is, what are the clinical evaluations of diagnostic tests are the most important in helping to assess physical therapy and rehab with the children of SMA, specifically non-sitters? And when we asked them, the most important, and we all came to the agreement, is to do the CHOP and 10. And a lot of you are familiar with the CHOP and 10, and that's a 16-item test, and it looks at items that for extremity movement, upper and lower extremity movement, head position in supine as well as in upright position, arm and leg activity in the upright position in sitting, as well as supported vertically, as well as supported in prone. Going down the line, one area that the neurologists look at that is called the Heine, and that's available out there. And that is a motor assessment that looks at skills specifically for SMA, and that looks at 8 skills, including grasp, ability to kick, head control, rolling, sitting, crawling, standing, and walking. What's important too is looking at pulmonary tests of airway clearance and their ability for pulmonary function. Continuing with evaluations of range of motion and looking at ranging of their arms and their legs, including hand and finger flexion and extension, ankle dorsiflexion and hamstring motions, and also neck range of motion. When we're thinking about evaluating sitting tolerance, we have to think about what is their positioning, their ability to control their posture, both in supine and in sideline, as well as in an upright sitting posture. And in that is their scoliosis, as well as kyphosis in their body in the upright position. Lower down in some of the evaluation areas, if you think about the first half, is really looking at their ability to move based on the CHOP and 10, based on range of motion and their pulmonary tests. When we think of some of the things that are important in our physical therapy evaluations, those are really the core areas that we look at. One area that sometimes we miss is caregiver burden, is what are some of the items that the family are important to them? What are their top 3 levels of need? And a lot of times when I come into a session, the first question I ask them is, what do you want to get out of this session? Or what do you want to get out of physical therapy? Certainly I can do range of motion, I could do a CHOP and 10 and do an evaluation to see how strong or how tight or how stiff. But the question maybe for the family is, oh, I can't move this child in and out of bed well, or I can't sit this child up. That caregiver burden gives me an opportunity to look at their plan of care and as well as set goal setting. Farther down the list of evaluation, another evaluation is the TIMC. That's not as familiar. It's based basically on the TIMP. It's basically a shorter version of the TIMP. And it's the name is Tests of Infant Motor Performance Screening Items. It looks at the same items as the TIMP, but has less items. One good paper looked at the reliability of the TIMC. It was actually from Kristen Kroschel, and she wrote about the reliability of that, and you can look that up, and it's really well done. Some of the other things that you can look at are strength tests, the ROM, which is the upper limb movement, and farther down the list is the Hammersmith. Again, we're looking at children that are non-sitters. And in this group of non-sitters, certainly they are developing strength, and they're developing the ability to provide movement against gravity. And once they become sitters, certainly the ROM and the Hammersmith become more important. But it doesn't say that in this group, that's the first thing that I would be looking at. The first thing certainly are more the postural control items, the CHOP and 10 items, and the respiratory items. One interesting new item that's not on this list that wasn't available in 2018, it's called the Attend. And it's basically a new assessment for older individual, adolescents and adults. And it is based on the CHOP and 10, but it's called the A10, which is the adult test for neuromuscular disorders. Now, if you check the community item, there's a chat on non-sitters, and there's a link to Dr. Day's lab. And under Dr. Day's lab website, you can actually, let me see if I can pull that up for you. And this is the A10, and basically it's a 14-item evaluation, and you can get a copy of the procedure and this test sheet under the A10 in Dr. Day's website. And basically we're looking at upper extremity movement, lower extremity movement, their ability to grip, which is very similar to the CHOP and 10, their head in midline, lifting their head in a semi-reclined position, their ability to balance in their wheelchair, their ability to move their arms, and their head control and their leg control in sitting, as well as their ability to use their hand, whether to pick up a 10-gram weight, as well as doing a 10 diagram using their finger to point to each diagram. So that's available through Dr. Day's website. which is Dr. Day Lab, and under the tab, the Intend, both the manual procedures, the Intend evaluation worksheet is under there. So that would be for older adults or older children that are difficult to get in and put into a prone position or difficult to lift up upright. So moving forward, the third question that we asked for this group was, what physical therapy and rehab interventions do you recommend to provide optimal care with children with SMA? And specifically for non-sitters, the main thing was stretching and range of motion. Since the very top topic of symptoms was lack of anti-gravity movement, the issue is there's an increased risk for contractures. So the main intervention, or the more important intervention to kind of look at first off, is can we minimize contractures? Can we maximize range of motion, whether it be by stretching and or bracing? And we recommend low load prolonged stretch for range of motion, which including bracing, positioning in a wheelchair or in bed, standing, and or casting. And standing would be with an assisted stander in a supine stander. That way you can adjust the position in an upright position from totally supine to partially upright. We also want to think about matching their exercise to an activity-specific goal. And that idea is really important because these children have very minimal anti-gravity movements, and we want to match the level of activity to their body weight. We want to think about these activities as either an open chain or a closed chain activity. And an open chain activity where their angle of activity and their angle of limb is against gravity. A closed chain activity is where their hand or their foot is on their support surface, whether it be on their wheelchair or on the mat. Now, it's important to look at both because we can certainly augment or to provide adaptations to their support surface to minimize the friction. Sometimes I put low friction surfaces on their wheelchair, whether it be by adaptive overhead slings, whether it be in their wheelchair or overhead slings over their bed. And we'll have diagrams of that in the patient examples. We also want to think about the external support surface. You can use water as long as the children are have the ability to breathe and able to keep their head above water. We have used neck supports, inflatable neck supports, so that they could provide external support so they can float in water. And that way, when they're supported in water, that low level of resistance, they could float also their extremities and use the body of water to provide support for their arms and legs and allow a low resistance movement. In the more important to least important are areas of bracing, wheelchairs, chest physical therapy, transfers and mobility training, mobile arm supports, exercise, and aquatic therapy. All these are important, but the idea is to minimize the contractures, maximize the range of motion, as well as the active movement. In case one, here's our first case of an infant. And this is a 10-month-old with SMA type 1.
So,
Yes.
Richard,
Yes.
sorry, I was going to say I have some videos, so I think I need
great.
to share my screen.
Okay. I didn't know you were here. I'm going to stop
Yeah.
sharing.
Thanks. All right. And I didn't mean to just take over. I just know that the videos are upcoming.
Yes.
So thank you for all the great introduction. And we already have some great questions on the app that I've been monitoring. And so we'll hopefully get to some time to answer those questions and talk about them. I look forward to a lively discussion with a lot of experience in the room. So it'll be fun to talk. But I think to get us just started and to think through clinically our cases and how we treat and assess patients. The first case, like Richard mentioned, is going to be an infant. So this is a 10-month-old boy with 2 copies of SMN2. He had symptom onset of about 4 months of age and was diagnosed at 6 months of age. To date, or I should say, at this time, the assessment, he was able to sit supported with fair head control. He did have the use of suction as needed from a respiratory standpoint, but was not at the time on any BiPAP or any other respiratory support. He was given a G-tube, and then nusinersen was initiated at 10 months of age. So at the time of his assessment, he had not received any disease-modifying therapy. He was receiving physical therapy and speech therapy, home health services 2 times a week for each. So this is just a little video to kind of show what his sitting posture, head control, those kinds of things looked like. And I think it's interesting, one of the questions that came up in the chat was about the fact that there is potentially increasing scoliosis in our patients as they are becoming sitters at an earlier age. And so I look forward to talking about that a little bit more with the group, but I would agree, I think that they are beginning to sit, but don't necessarily have the trunk control to support them, and so scoliosis may become an issue. So that being said, when we really looked at this young boy with in respect to impairments and activity limitations and then participation restrictions, he did have difficulty breathing at presentation. He obviously had weakness and hypotonia. He also had some difficulty swallowing, had a weak cry and a weak cough, and those were his presentations when he presented to the ED. He was unable to roll at 10 months of age, unable to sit unsupported at 10 months of age, fair head control, and then unable to push up into prone on his forearms. And then from a participation standpoint, he was having difficulty with feeding. From an impairment standpoint, obviously range of motion could be assessed, and specifically really noting any ulnar deviation at the wrist, hip and knee and ankle contractures that might have been present, cervical mobility, and overall strength and function. From an impairment standpoint, or I'm sorry, from a function standpoint, the CHOP and TEND was performed, as well as just developmental milestone checklist or assessment. The Heine 2 could have been a appropriate outcome measure, and the WHO motor milestones might have been an appropriate measure. And then patient-reported outcomes, the PD-CAT could be used, as well as there's a type 1 caregiver questionnaire that could be helpful. When we really think through treatment plan and goals, I think this is where, as therapists, we start to question ourselves now that we have disease-modifying therapies in our expectations, and really, how do we set goals, and how do we determine improvement or responders versus non-responders? And looking at those things can be challenging when we're in an uncertain kind of time frame or time with our patients that are getting disease modifying therapies. But in general, I would have said that from a short-term goal standpoint, within about 3 months, we would hope that he would be rolling with assistance. Head control would have improved while sitting with assistance, and then reaching or lifting with his bilateral upper extremities in a reclined position, and even bilateral lower extremities in a supine position would be a goal that could be achievable. At 6 months, rolling from back to stomach independently, good head control while sitting independently for 10 seconds, being able to push up on elbows and prone, and then also not forgetting that we want to minimize any potential contractures in the upper or lower extremities. So to do that, stretching could potentially be included in your plan. And specifically with this boy, knee extension, he just had some issues with getting the knee completely straight, and so looking at managing that from a stretching standpoint. I don't think he was at the point where you would need bracing, but it would definitely need to be something in the back of your mind. Motor development wise, from an intervention standpoint, working on rolling, working on sitting and postural control and prone positioning. From a positioning and bracing standpoint, using AFOs, especially in any kind of standing posture. And then we used kinesiotaping for wrist and hand alignment. He wasn't at a point where he needed wrist splints by any means, but just using that kinesiotape was beneficial for him. And then he did not have any present contractures. Again, I mentioned knee extension was a little bit limited. Ulnar drift was a little bit present, but taping and stretching seemed to work for that. So just considerations of, Richard went into really great detail about different interventions in mobility and exercise. So just kind of capping on that, the potential use of slings and springs to unweight objects and initiate and encourage movement against gravity. Using lightweight toys, using wedges or pillows for propping and positioning, and obviously aquatic therapy is something that would be beneficial for a patient like this. We did refer him to seating and mobility for an adaptive stroller at that age. It wasn't necessarily, he was still fitting in his car seat, but eventually looking at car seat versus car bed needs is something that you may have to keep in the back of your mind. Referral to the orthotist in order to look at potential need for AFOs or KFOs for standing and the standing frame for standing. He did not need head pods or a headmaster or any kind of head support, but again, in an infant that presents fairly early, these may be things that you may want to look at. This is the update. He's now 4 years old, continuing on Spinraza, so he's still on nusinersen. He now sits unsupported, and he's an adorable little boy. So moving forward, the second case is a child, a 5-year-old, 5.5-year-old female with 2 copies of SMN as well, or SMN2 as well. So she had symptom onset of 5 to 6 weeks, so a little bit earlier onset with noted limited arm movement and hypotonia. She was diagnosed at 2.5 months, and highest motor function achieved at the age of 5.5 is sitting independently and standing with assistance. She, at this point in time, has nocturnal BiPAP, uses cough assist, CPT, and suction as well on a regular basis. She does have a G-tube, but her intake orally is increasing and improving. And she was in trial. She received Spinraza through the CS3B study and started in June of 2015. So she was 5 months of age at initial treatment. She currently gets 2 times a week physical therapy. It was changed to virtual therapy during the pandemic, and she did miss about 5 weeks before that was set up. She's also scheduled to begin serial casting for ankle plantar flexion contractures. It was also shut down or delayed due to the pandemic. She's not receiving any occupational or speech therapy at the moment, although speech therapy is recommended, especially for swallow and for feeding. And then from a physical activity standpoint, she uses a standing frame and a bicycle every day. So she obviously, in impairment considerations, she has upper extremity and lower extremity as well as trunk weakness. She does have bilateral plantar flexion contractures, ulnar drift, difficulty swallowing, and delayed speech. She has limited mobility, difficulty standing, and poor postural control from an activity standpoint. And then from a participation standpoint, starting school, just difficulty with that independence in the school setting. So obviously we would do range of motion or goniometry to look at plantar flexion contractures and different range of motion limitations. We can start to use manual muscle testing or dynamometry for strength assessments. But functionally, we probably would look at the Hammersmith expanded, as well as the revised upper limb, and then pulmonary function testing. From a patient-reported standpoint, the PDCAT, the PROMIS, the PEDS QL, and the ASCEND could all be used to assess function and fatigability in this patient. Short-term goals with her would be being able to stand with her KFOs with minimal assistance for 5 minutes. She's starting to work on quadruped positioning with good head control, being able to maintain that head control for 3 seconds. And then also she's working on high kneeling, working on that ability to hold for 10 seconds. We would then hopefully see her progress then to standing with less of a support with an AFO, potentially also crawling, and then maintaining then half kneel from a standpoint of a goal setting consideration. So interventions are similar for stretching as far as positioning and bracing and contracture management. You can see here she was in a prone propped position with a wedge. These braces that she has on her arms are to help with that ulnar drift to keep her wrist in a more neutral position, but still leave her functional so that she has the ability to use her hands as needed during the day. And then from a mobility and exercise standpoint, really working on all of those things from functional issues as far as being able to stand, crawl, walk, transfers, working in quadruped and kneeling, and using her bicycle daily. So you can see she has different devices to help with stability. So she has obviously a TLSO, she has KFOs, she's able to, and then this middle picture, she actually also has a SPIO vest to help with stability from a trunk standpoint when she's working. She has that on as well in this last picture where they're actually working on walking, taking steps. And then durable medical equipment, again, she has a ton of things. She's got the SPIO, the TLSO, AFOs, KFOs, using kinesio tape, as well as her wrist splints. She has a wheelchair with power tilt. She also has a manual chair, a stander, a walker, and then respiratory equipment that were mentioned, BiPAP, cough assist, and a CPT vest. So it takes a lot to manage a patient from a durable medical standpoint. And then this is her most recently, she does have improved endurance, and she has less sensory aversion as well. She's tolerating both different oral textures better. So again, I mentioned that her oral intake is improving. And then, like I said, she is taking steps with assistance now. And then our last case is an adult. She's a 22-year-old female that has 3 copies of SMN2. She had a symptom onset of 10 months of age, diagnosed at about 18 months of age, and she did sit unsupported into her teens and walked with assistance earlier on in life. But she has since lost the ability to sit unsupported, and so has continued to decline as she has aged. She does use nocturnal BiPAP and cough assist as needed. She had a scoliosis surgery in 2010, and then she did initiate nusinersen in June of 2020. So I've only seen her, actually I've not seen her due to the pandemic since she initiated treatment. And then she does not have any formal therapy or regular activity, which I feel like I see that in adults more frequently than in children. But I get the question from adults, is it necessary, more often? And so I think that's something important for us to discuss. This is a video just to kind of demonstrate, this is her upper extremity function. This is how much she definitely has movement in the bicep against gravity, but proximally at the shoulder, that's as much as she can lift. And again, I remember she is unable to sit unsupported. So she has upper extremity and lower extremity as well as trunk weakness. She does have hip flexion and knee flexion contractures as well as plantar flexion and elbow flexion contractures. Her elbow flexion contractures aren't terrible, but they're definitely there. So it's something that we need to monitor. She has difficulty with feeding and grooming and mobility and transfers, and then poor sitting tolerance and difficulty with independence attending college courses. So our range of motion manual muscle test, as well as endurance shuttle test, box and blocks, or the 9-hole peg test for fatigability in the upper extremities could be something that we could potentially utilize in our patient. The ATEND, which I'm so glad that Richard gave you more insight into the ATEND that can be used in this patient that obviously cannot do some of the CHOP intend items, and so it's a really useful assessment that hopefully will be validated soon. The revised upper limb to give upper extremity functional insight, and then pulmonary function test as well. In the adult population, I really like to use the EK2 to give us insight into some more patient-reported functional measure, as well as the potential, you could potentially use the SMA-FRS. And then also in the adult patients, in addition to motor function, while we're not getting to see the speech therapy breakout session today, I'd be interested to see what they choose to use, but we use the Voice Handicap Index and then the EAT-10, which are both patient-reported measures to look at both strength of voice and ability to eat. So goals for this patient were really from what she wanted. She wanted to be able to roll to improve her mobility in the bed and improve her independence from a bed mobility standpoint. And she wanted to be able to improve her postural control so that she could shift her weight better without assistance, and particularly for going up and down ramps, so that she didn't need assistance when if she were to fall forward. She wanted to be able to independently pull herself back into extension while sitting in her chair. She also wanted to be able to lift her arm into place onto elevated surfaces to help with things like brushing her teeth, and then work on sitting independently as well, and hopefully regain that ability. So interventions to work on that obviously would be, well, we did not mention contractures, but we definitely want to stretch or use bracing to address those contractures. AFOs is needed, and then obviously wrist or hand splints if she had wrist or hand contractures, which she did not, but those could be used especially at nighttime. Mobility and exercise, really with her, it was about encouraging more activity daily. And so we talked about using an upper extremity cycle and working with core and stability type endurance. And then from a durable medical equipment standpoint, in some patients, you may want to consider overhead rail or Hoyer lift systems, power chair with tilt, recline, and elevating legs, manual backup chair, shower and toilet chairs, hospital beds, and then splinting as needed. So again, just to wrap up, considerations for non-sitters, we've said this all morning, that multidisciplinary care is essential in this current era and arena of evolving phenotypes, and we have to consider that we are going to have patients that do not respond to the disease-modifying therapies. And so we need to make sure that we are managing those patients, as well as the ones that do respond, but potentially are not responding in a typical fashion, that they still have some developmental concerns. So we need to make sure that we're monitoring those patients in a multidisciplinary system. Traditional outcomes for SMA, like the Hammersmith and the CHOP, or in the CHOP and TEND, may be beneficial, but we may need to also, for those responders, start looking at norm referenced outcomes. And so those are things to consider. And then obviously there are some disadvantages from a standpoint of the lack of funding or resources for patient equipment or therapy. And then we really don't have a lot of research and know exactly what the effects of exercise and rehab are with and without disease modifying therapies. And so that's a limitation that we really have to work through. And again, that's why we have these conferences. These are some community resources that are available, and I think that tomorrow the group will talk a little bit more. For sake of time, I'm going to just move forward so that we have some time to have questions. And again, these are just our rehab goals for non-sitters: optimize function, optimize tolerance to various positions, and minimize impairment. Pretty simple, right? All right, so I'm going to stop sharing. And I don't know, let me see, Richard, did you happen to have the app up? Do we have any questions, or does anybody want to ask a question?
Yeah, there was a couple of questions on the Q&A list, and there was a comment saying that I have seen an increasing issue with scoliosis in patients with 2 copies who are treated with nusinersen or gene therapy. I would start to move this farther up the chart, meaning up the chart of both symptomatology and in evaluations. Although these kids are mostly sitters at this point, but started as non-sitters technically. Thoughts on this from others would be interesting. And then I posted an article, and it actually describes both cervical rotation, chest deformities, and pelvic obliquity in patients with SMA. And that's out of a journal called, it's really a small journal, BMC Musculoskeletal Disorders. And the author is, I can't pronounce the name, is Agnieszka, Stefan. So that was the first question. And if anyone else has any other comments on scoliosis, it's one of those things that we try to both treat, both with positioning and bracing, but is difficult because when they're in upright position, they have a tendency to collapse. Leslie, do you have any thoughts on that?
Yeah, thanks, Richard. No, not necessarily to add to it, other than I agree. I'm seeing that, and just getting to that sitting posture without the available strength from a trunk standpoint. I think that's something that we'll need to see. I think it was interesting that it was said, you know, that should be considered in the standard of care. And I just want to remind everybody that standard of care was written before we had commercially available disease modifying therapies. And so I'm sure that as the phenotype changes, we will hopefully see an update in that, and maybe see some more literature on scoliosis.
Yeah, and someone made mention of a dynamic orthosis, like the Spiro or some other type of orthosis to use as they're trying to gain strength in sitting and in upright positions. And I think that's a good way to start if they have some strength and they have some initiation of extension, thoracic extension. If they don't, then I go to more of a semi-rigid or a rigid brace in the upright position.
Yeah, great point. I think you noticed in that case too, she had both TLSO as well as that SPO, so she was able to utilize both of those in different tasks. Yeah.
A second question was, a lot of research seems to be saying that splinting doesn't make a big difference in maintaining and improving range of motion. What research do you know of that supports splinting in SMA? I personally don't know of specific research with splinting in SMA, although splinting in general is really palliative, and bracing doesn't halt the progression of contractures. It's really the recommendations of the standard of care measure was to provide a guideline for use of braces. And the guideline was to wear braces at least 5 days a week, at least 60 minutes. In my personal practice, I usually recommend bracing daily and bracing greater than 8 hours a day if it's a static brace, if the goal is to maintain motion. I usually use it overnight. Sometimes I will also alternate right side to left side if the tolerance, to improve tolerance, both in the hands and in the feet. Any thought of that, Leslie?
Sorry, I was reading questions. Oh, I'm sure you answered it well.
The third question is, at what age is recommended to start the ATEND? And this has been validated. Now, if you can go on to the website, John Day's lab website, you can actually get a lot of information there. And right now, it's used for larger individuals who are non-sitters, basically larger children and or adolescents or adults, where you can't move that child through all of the different item sets, like the upright item set or the prone position item set in the CHOP and 10. So they developed the ATEND, and there's not a specific age group, and it's currently, we're gathering data to see the validity of the ATEND.
And Sally just posted the link in the question on the app. So if you can just click on that link to get to it.
The next question is, are your patients getting insurance coverage or funding for things like standing frames, mobile arm slings, and other exercise equipment? I am getting approval for supine standards. A lot of our children are in supine standards for non-sitters. The mobile arm slings, it's usually a case-by-case basis, and also what type of mobile arm slings. The basic mobile arm slings, yes. Some of the more complex ones with the rubber bands, not always. Any thoughts on that, Leslie?
Yeah, I agree. We do get supine standards usually approved. And I think that it varies based upon obviously where you are and what insurances they have. So it's kind of a difficult question to answer, but some of the things are being approved with different private insurances. It's harder with Medicaid, but some private insurances are definitely a little bit more willing to approve with different letters of necessity.
I think we covered most of the questions on the Q&A tab. Are there other questions from the group that people have?
I don't see a chat. I think you have to do it through the app. And I don't know, Natalie, can they unmute themselves if they want to talk?
Yeah, they should be able to. Please let me know if you're
Okay.
not. Yeah.
Can I ask
Thank
a
you.
question, Leslie? This is Kirsten.
Yeah, I'd love for you to.
Actually, I'm not sure. Maybe this is better for the sitter group, but unfortunately, I can't attend tomorrow because I have patient care. But I have a client she's a type 1. She has 2 copies. She's been on nusinersen. She was in this original since she was 5 months old. And she's 5 now, and difficulty potty training because she often can't tell that she needs to urinate or even have a bowel movement. And I have not really encountered this with these kids before. And I was kind of wondering if other people had, if you think yeah. So I thought that was unusual. I understand the muscle control part of it, but the sensory part, it was confusing for me.
Yeah, I'm glad you asked the question. Actually, the case that I presented, the second case that sounds like it's a similar situation. She's 5.5, was early on, given Spinraza early, and she has the same issues. But she also has those feeding aversion type of issues as well, some sensory issues. And so I don't know if that's I don't know if that's a trend or if it just happens that you and I have kids that are similar and look the same. So I don't know,
Well,
Richard, or
I'm not sensory, from a mouth or bulbar issue, but she can't actually tell that she needs to pee. Like,
yeah.
Do you know what I mean?
Okay.
She doesn't even know that she needs to.
Right. Initially with my patient, I really was focusing more on the stability and being able to be stable while toileting, thinking it was more of a motor function issue. But she's still having difficulty with toileting.
I haven't had that issue with the sensory portion of it. Most of these kids don't have issues with sensation, both on their extremities or ability feeling when they have to go to the bathroom. Although I've had children go to and from use of diapers because of both communication issues and also behavior issues. And that's been a big thing, is they're unable to have effective communication to say, oh yes, I feel, or I have the need to go, or I want to go. And over time, they just don't communicate it anymore. And so the teachers don't put them on the potty train. So it's really both a social and a functional issue for this child, not so much a sensory issue. The only time I've ran into a sensory issue once before, but it was mainly because the child was hypersensitive with touch and had an issue with the sound of the toilet and the texture of the toilet. So we went with a toilet that was a freestanding toilet as well as a padded seat, and that's different than your problem.
Anybody else have anything to add?
Real quick, it was in the Q&A, but those ulnar deviation braces you had on that case too, are those like off the shelf or something you guys made custom?
Hey, Melissa, they were custom made by an OT in our clinic. Okay. And it was basically, it was a pretty simple, I can send you what we did if you would like me to do that.
Yeah, that would be awesome. We actually have an OT that's doing some 3D printing, so it'd be cool to get him some ideas for stuff like that.
Okay, I'll send you the information.
Thank you so much.
We have another question on the Q&A, and the question is, can you share your functional criteria for serial casting? Are you only casting kids that are no longer standing? I do serial casting for children that are non-sitters that are still being placed into supine standards. If they have any ability to bear weight, I put them into AFOs. So I try to do serial casting so they can fit in AFOs to put them in a supine standard. I don't always do a long leg cast because a lot of these kids will also have hamstring tightness. I allow them to compensate that position in the supine standard. The functional criteria is really the weight bearing. Are they able to tolerate weight bearing, and they also tolerate the upright position?
So I'll just say that there's and Kristen, I think, is on the call. So feel free to jump in, Kristen. There's a group of us that have been actually discussing this and trying to think through what would be recommendations and having that available for us as a community. So it's been an interesting project to determine what different centers are doing. And Kristen, do you want to jump on, or I don't even know if you're listening or here.
Sure, I am. Yeah, so I think that we found that there is, particularly we presented some case studies across some centers recently, and I think there is a lot of variability, but I think one of our initial intents on taking on that project and starting those discussions was to hopefully work to some collaborative guidelines for the community and for different types of patients at different ages and stages. And it will likely progress out as we move forward to a Delphi study. So some of you may see that survey come your way in the future, but it's been a really interesting process. But I think, like, your questions about it are good. I don't think we have enough answers and information yet, and we need to sort of try to figure out the best way to organize things so that we can maybe collect some data that will give us some better information about casting. I think some people have done some really good, have had some really good successes with casting, and then others have had less success. So I think it's a little bit of a mixed bag right now. And we need to figure out what's the safest in regards to length of time and type of casting and amount of stretch, et cetera. So be on the lookout for more news on that in the new year.
Thanks, Kristen.
There is another question on the Q&A. It asks, when trying to get adults to qualify for risdiplam or nusinersen, have you noticed any difference between using the ROM versus the A10? And I think in our practice,
oh,
go ahead.
No, I was just going to say, to be quite honest, the A10 it's only been used for the last 6 months or so. And so we also do the revised upper limb as well. And so we're doing kind of a group of different outcome measures. And I have not had any issues using the revised upper limb or the upper. I do both. I end up doing both the upper limb and the revised upper limb, depending on the insurance. But the A10 is done in conjunction with those in our practice here.
Yeah, I would agree too as well. And again, the A10 is fairly new, and I think you also want to get not just one data point, but multiple data points. I usually do these outcome measures anywhere from 3 to 4 months in series. That way you can get a trend of whether they're maintaining their function or they're decreasing in function or improving in function. There's another question that asks, does anyone do respiratory testing in scoliosis braces, TLSOs, SCARCHOs, to make sure they don't impair respiratory function? This has been our team's concern with SPIDOs braces due to their compression nature. I haven't done testing with SPIDOs or other types of TLSOs, although we've had cases of children that have their respiratory impeded by the TLSO. Specifically, we had a child who had a semi-rigid TLSO, a non-sitter, and then every time we put the TLSO in sitting, their saturations dropped. Some part of the compression and the posture wouldn't allow them to maintain their saturations at their higher levels, although they're able to sit in their wheelchair at the same position. But most pulmonary centers will look at their pulmonary functions without their TLSOs on.
We do the same. We do our PFTs without bracing.
There's actually a fairly new article that talks about the respiratory impact of novel therapies for SMA. And that came out of pediatric pulmonology, and I believe it was this last October 2020. So it gives you some overview of kind of the new drugs and also the pulmonary impact of the new drugs on SMA. Another question is, do any of you have recommendations for intensity of exercise to strengthen patients safely? Again, intensity of exercise to strengthen patients safely. And for me, I actually don't do a lot of intense exercise with children or adults that are non-sitters. I mainly look at their ability to function, and can I compensate their function, or can they augment their function to provide them with a new skill? Can I give them some tool, some adaptation for a new skill? And then I can look at that, see if they can do that new skill or that activity more frequently. So I look at frequency throughout the day and function throughout the day. Can I improve their frequency? Can I improve their function rather than intensity? Do you have any thought about intensity, Leslie?
Yeah, the only thing I would say is that, based upon what we found in the literature review for the standard of care document in 2018, there is a table that does kind of talk a little bit about stretching and strengthening from a standpoint of there aren't particular or stringent guidelines, but really just focusing more on moderate intensity and knowing that that is safe based upon the literature that we had at that time. I think there are some exercise studies going on, and again, those will be things that look for in the future as things are published and looked at a little bit in more detail.
There's another question going back to serocasting. Is there a risk for further targeted weakness in the muscles that are serocasted? Pros and cons of range of motion versus loss of strength and length of casting. Certainly, length tension and length of muscles is a consideration. I think you have to think about, and that becomes even more of an issue with surgery, right? We think about after a Achilles tendon lengthening, I see that a lot of times you'll see a half-grade strength deficit after a Achilles tendon lengthening. In a casting situation, it's a little bit different with these non-sitters because they're weak altogether, and we put them in a cast. And I typically, when I do a serocasting, actually do it for 3 days, 3 to 5 days, and then I take it off. And they're off the serocast in a bivalve for 3 to 5 days. And I do another cast after that. So I'd almost do a series of casts every week or so over 4 to 6 weeks. And I try to have them maintain a position. When they're in the serocasting, I also do the heel where I build up the heel so that I can actually put them into the standard. So I augment the serocast so I can use that almost as a mock-up for a brace. You kind of have to think about, can I, is the functional benefit of casting important enough that you'll put them into a cast for about a month? And I think there are ways to go around that by doing bivalves, by making the cast open in the front and providing some type of movement while they're being serocasted. Any thoughts on that, Leslie?
No, I agree with you completely. And just monitoring within the time of casting function. And obviously, if they're starting to lose any function in the cast, getting them out of the cast. But we do use bivalves fairly often, that it seemed to be beneficial for different reasons.
Yeah, I mean, there's a big con to this, right? The casts are very heavy and they can't move their limbs. They can't, flex or extend their knees or their hips if they don't have that strength. But the positive is if you can move their ankle in a better position, they can get into a standing position, or you can adapt their cast into a standing position and they can get some weight bearing to that leg.